Okay, so we're talking about Joey. He was 7 years old and previously healthy. His physical exam reveals very swollen knees and knuckles of his hands. There is a pink rash over these areas. He has a blotchy mosquito bump type rash on his trunk and his back. His throat is a deeper pink than it should be, and I can also feel enlarged lymph glands in his neck. Joey says his knees are tender, but his hands aren't bothering him too much. Mom says he isn't allergic to anything, but his younger sibling and her mother are both allergic to penicillins. Mom also tells me that Joey has had amoxicillin in the past without any problems. By day 10 of an effective antibiotic, Joey's throat should look normal, and he should not still have very swollen lymph glands in his neck. Therefore, I order a quick strep test, which comes back positive. Joey still has strep. Could that be causing all of his symptoms? No, it's not just the strep. So, in 30-plus years of pediatrics, I have not seen this in the office, but I know what it is. Joey has serum sickness, and that's what I'm going to talk about today. Serum sickness is an allergic reaction triggered by immune complex formation and is characterized by the development of fever, malaise, 100%, rash, 93%, inflamed and painful joints, 77%, all of which are affecting young Joey. Additional symptoms that could occur include gastrointestinal complaints, 67%, headaches, 57%, blurry vision, 37%, and shortness of breath, 20%. It was first described in the early 1900s and occurred in patients who had been injected with non-human antitoxins, which the body sees as a foreign protein, for treatment of diphtheria and scarlet fever. Classic serum sickness is rarely seen now because antitoxins are limited to treatment of botulism, rabies and snake, scorpion, and spider bite. Joey actually has a serum sickness-like allergic reaction, because you know we like to put everything by initials, so this is SSLR, to the amoxicillin that he has been taking. It can be caused by beta-lactam antibiotics, ciprofloxacin, sulfa drugs, bupropion, griseofovin, tetracyclines, streptokinase, and metronidazole, which is a wonder why we don't see it more often of all those things, because they're used here frequently. Serum sickness is a type 3 allergic reaction, which causes immune complex formation and subsequent inflammatory cascade activation. The immune complexes are usually cleared by mononuclear phagocytes, but when there is a high concentration of these complexes, it's difficult for the phagocytes to clear them rapidly. This results in deposition of large immune complexes in the arteries in the skin and also in the kidney. Mast cells and basophils are activated and they release histamine, which causes hives. Histamine release also causes increased permeability of blood and lymphatic vessels, which results in leakage, fluid leakage into various tissues. We see this in the swelling of his joints. Other inflammatory mediators are also released. Laboratory studies have not been particularly helpful in establishing the diagnosis of serum sickness. The patient's history of his illness and the findings on the physical exam lead the physician to the correct diagnosis. The annual incidence of serum sickness is declining as foreign proteins used in medical treatments become more refined. The likelihood of developing SSLR is dose-related. Larger doses cause an increased incidence. It's also affected by the type of antigen. Anti-rabies serum has a 16% incidence versus tetanus toxin, which has a 2.5 to 5% incidence. Antibiotic-induced SSLR occurs more frequently in children younger than 5, although my patient's 7. Serum sickness is typically self-limited, this is the good news, and resolves on its own within 1 to 2 weeks. The prognosis in patients without internal organ involvement is excellent. However, complications may include vasculitis, acute renal failure, glomerulonephritis, anaphylaxis, and shock. The mainstay of treatment is to stop the offending substance. Everybody Antihistamines and anti-inflammatory medications such as ibuprofen provide symptomatic relief. A brief course of corticosteroids may also be helpful. Since this is an allergic-mediated reaction, the patient should never take that medicine again. If he did, subsequent reactions could be more severe and lead to anaphylaxis and shock. So, what did I do for my patient Joey? Well, you may remember that in addition to serum sickness-like reaction, he also still has strep throat. Because 10% of people who are allergic to penicillins are also allergic to cephalosporins. I decided that I wouldn't use Omnicef, which is a cephalosporin, because I just didn't want to complicate things. Clindamycin would have been a good choice, but Joey's 7 and doesn't swallow pills yet. And clindamycin tastes and smells horrible. Even when you flavor it, it's extremely difficult to get anyone to take it. So I finally settled on Biaxin, which is a macrolide. I also started Joey on corticosteroids and gave him a 5-day course. Joey came in for follow-up 2 days later and looked like a different child. The swollen joints had markedly improved and he was feeling much better. No more fever or malaise either. Yay! I'm Dr. Madeline Murad, and my pediatric office is here in Alpharetta. I am a great referral for your cousin with 4 kids who just moved to Johns Creek. Set up a coffee and introduce us. I will provide them with excellent medical care.